So we're going to talk about sleep and neurological disorders, so another one of the MLA presentation series. I actually think this is the last recorded MLA presentation series, so I'm not doing it in alphabetical order. So contents, we're going to talk about sleep, what it is, why we think we do it, we don't really know. And we'll talk about common conditions, because that's not part of your specific individual diagnoses list. So sleep apnea, narcolepsy and cataplexy, some of the parasomnias and neurodegenerative disorders. So why do we sleep? Nobody really knows. We know that if you do not sleep, you get a catastrophic psychiatric reaction and then you will eventually die. And we know this because there are very rare conditions like familial fatal insomnia, which you do not need to know for your MLA exam, whereby the brain loses its ability to generate sleep and people become very unwell and die. And we're unable to prevent that. The brain needs to sleep. We think that probably it has roles in consolidating memories, in cleaning out waste from the brain structures via the CSF. We think that probably a lot of neurodegenerative disease comes as a result of reduced ability of the sleep processes to clean out waste, we think. And there are key structures that are involved in enabling sleep. So there's something called the reticular formation, the raphe nuclei. There are different areas of the brain stem. There's an area of the brain called the locus coeruleus, but essentially the reticular formation, the raphe nucleus in the pons and medulla are involved in generating sleep. Sleep comes in phases. So there's REM sleep, which is rapid eye movement sleep, and that's what dreaming is. So when you dream, your eyes move, your muscles twitch, and your brain is fairly active. And we think that probably dreaming is to do with processing memories and experiences, and certainly you often dream things that are related to what you've been thinking about or doing in the days. Some people recall more of their dreams than others. And we have non-REM sleep, which is more of your sort of restful sleep, and there's no eye movement, no muscle twitching, and that comes in phases, so 1, 2, 3, 4. 4 is the deepest and most restful sleep and tends to come at the beginning of the night, and you tend to dream more later in the night. So more REM, more dreaming towards the end of the night, more deep sleep towards the beginning of the night. So sleep apnea, so a really common one. People with sleep apnea have, or obstructive sleep apnea at least, have obstruction in the structures that allow you to breathe when you're asleep. So when you're asleep, obviously you're lying down, you relax, so the muscles around your face and your throat and your tongue and your other structures around the face all relax. So there's reduced tone, things get floppy. If you are a man and a bit bigger and you have quite a wide chunky neck or big fleshy structures in the oropharynx, like big adenoids or big tonsils, then you're much more likely to snore and you're more likely to reduce the airflow, the ability to breathe at night, and that's why you snore. And if people snore a lot and there's not a lot of airflow getting in and people have reduced breathing, not only do you snore, you start to have apneic episodes where you don't breathe and then you sort of gasp. Some people stop breathing altogether and they may wake themselves up because they stop breathing entirely, or their partner may get alarmed and wake them up. Receding chin as well. So if you have a chin that's quite small, that means there's a reduced area for air to flow through. There is a central form of sleep apnea which isn't to do with peripheral structures, but is to do with the brainstem generating breathing, and that can be caused by things like neuromuscular issues, so unable to sort of generate the movement of breathing, so breathing is reduced. And obviously when you're lying down, there's more weight of the body and there's more pressure and everything goes floppy even more, so you breathe less efficiently. And if you're sedated or if you have lots of opioids on board, this can worsen things. So if you have a large man that snores with a thick neck, who snores a lot, who's then put on a lot of opioids, who puts on weight because of the opioids, he's going to have much worse breathing overnight. And the symptoms you get from that: early morning headache, dry mouth, fatigue, that suggests poor oxygenation overnight, which could be obstructive, could be central. We know that patients with MND, for example, who have progressively worsening ability to oxygenate overnight have these same symptoms, and we need to ask about those. I've already talked about bed partners, talking about really loud snoring, gasping, not being able to breathe properly. We have something called the Epworth score and also stop bang, which was designed for driving, the clues in the name, looking at the tendency to fall asleep if people aren't really getting good quality sleep at night, because these people are prone to micro sleeps. So they just drop, no warning, often not aware, and they will just fall asleep for seconds or a minute or so and not be aware that they're asleep. And this is quite common in drivers. We see it in dash cams and in lorry drivers who, I don't want to make a generalisation, but I'm from a family of wagon drivers. It's not a very active job. People often get overweight. And there's quite a tendency for wagon drivers to have things like sleep apnea. Now dash cams are mandatory, and we do see people having micro sleeps and crashing. And when you're in control of a huge vehicle, that can be devastating. So we are very clear that if somebody has active sleep apnea and is untreated, they cannot drive. And that is a legal issue, and we've already done the DVLA talk about medical legal issues in driving. So narcolepsy and cataplexy, so these are innate brain problems to do with sleep and sleep generation. I think this is interesting. So it's a very rare disorder. We think maybe 1 in 2,000, but a lot of the cases are quite rare and undiagnosed. And it's to do with a chemical called orexin, which orexin is involved in sort of maintaining sleep and awareness. So we should either be asleep or we should either be aware. We shouldn't be somewhere in between. And in narcolepsy, people don't really achieve good sleep overnight, and they're never really awake during the day. So they live in this kind of limbo state, this exhausted limbo state. And they are very, very sleepy, that's hypersomnolent, and they just have irresistible needs to fall asleep during the day. And they often have micro sleeps like people with sleep apnea do, but they also kind of go into dream states during the day and do really weird things. Like I had a clinic once with somebody who had narcolepsy, and they kept sort of going into this kind of dream state. Very nice guy, very normal guy, but when he was sort of in this weird sleep state, he kept trying to put his pen in my ear, and obviously you sort of orientate them, and then they're aware and they go, oh God, I'm sorry. But they never sleep well overnight. There's this kind of belief that narcoleptics just sleep all the time. That's not true. They never sleep well, and they're never truly awake. They may have cataplexy. We think maybe about 2/3 have cataplexy. And cataplexy is to do with muscle tone. So when we are asleep, so we are tree dwellers, so we evolved from tree dwellers, we should be still. So we can twitch a little bit and move a little bit as we dream, but we don't sort of move around and enact our dreams. That is abnormal, that is pathological. We think that's because we are evolved from monkeys. We would have been up in trees to get away from predators. If we were thrashing around when dreaming, we would have fallen out and been eaten by a tiger or whatever. So human beings should be still when we dream, or pretty still. And there's a structure called the locus coeruleus, the blue body in the brainstem, that maintains that, keeps us still. We think that in cataplexy, that sort of paralyzed state of sleep is abnormally turned on. So, but instead of being generated by sleep, it's generated by extremes of emotion. So I have a few patients where it's laughter. So somebody tells them a joke and they just go, oh no, and they just sort of crumple to the ground and their eyes close. And I had one girl who had a ponytail, and she used to just flop to the desk when somebody told a joke in school, and someone had to grab her ponytail and sort of bring her head up. I'm not sure if I really don't know the evidence, and I've looked this up, and that there's no real evidence known. But it seems to me that cataplexy in women, it tends to be laughter, humour, something funny that triggers it. In men, it's more often when they're angry. So I had a guy that got really angry at another driver. This is how it presented, and just sort of like slumped in his car and couldn't move. But he was conscious, and obviously he couldn't drive until that was treated. And he also had mild narcolepsy, but it hadn't really presented itself. It was the cataplexy. And we can treat it with things like venlafaxine. But it's an extremely interesting innate primary sleep disorder. So REM behaviour disorder. So we talked about REM, dreaming. So REM behaviour disorder is abnormal behaviour of the body when dreaming. And that's when you aren't paralysed. So instead of cataplexy, where the paralysis is turned on when it shouldn't be, when you're awake. In REM behaviour disorder, your paralysis doesn't turn on when you're asleep and dreaming. And we see this quite often in Parkinson's disease. It can be prodromic, so it can be years, 5, 10 years before the Parkinson's arises. But we know that in 80 to 90% of people that have this, they will develop a form of Parkinsonism. Okay, so patients enact their dreams. They quite often, feel like they're being pursued. So they'll run, they'll punch, they'll run, they'll scream, shout goal, you know what I mean? Bed partners often get whacked by accident, but pursuit, sport and sort of heightened emotion are quite common. Sometimes it's more benign and people sort of laugh and say, oh, give over, you need to go and get the bread. But it's often sort of high pressure pursuit and sort of activity. When we see these patients in clinic, it's quite a difficult conversation, because what we don't have the means to do is prevent the development of Parkinson's disease, and we know the risk is the risk is high. We think that deposition of abnormal proteins in Parkinson's disease, so alpha-synuclein and Lewy bodies, are preferentially deposited in that little bit that turns on the paralysis correctly during dreaming, the locus coeruleus. We think that the Parkinson's proteins like to settle there early, and that's why it's a herald of Parkinson's disease in the future. Similarly, restless legs and periodic limb movements of sleep, they occur more in disorders like Parkinson's disease, but lots of people have restless legs and periodic limb movements who do not have Parkinson's disease and will not get Parkinson's disease. And it's a compulsion to move your legs, very unpleasant, horrible, burning, or agitated feeling. It used to be called Coronation Street disease because it used to start at around 7:30 p.m. That's really, really typical. If you're not British, there's an awful soap called Coronation Street, which my mum loves, and it starts at 7:30, so they used to call it Coronation Street disease. It's really hard for people to sleep. It's very distressing. People give up, get up, start walking around, and almost always movement and the feeling of bare feet on a cool floor tends to be soothing. And it just destroys the sleep. People are afraid of the evening, and it can also, as it gets worse, possibly also affect the arms as well and get restless arms, and can get earlier and earlier in the day as it worsens. It tends to be worsened by blood loss, so low iron levels. So you can see it anew in people that have had big surgery, and then you're called to see them and they're like, my legs are really hurting, I can't keep still. And it's because they've lost a lot of blood. They've become anemic. You give them a blood transfusion or iron replacement and it goes away. So that's something really to be aware of. The similar sort of thing happens in pregnancy. So women can become more anemic in pregnancy, and restless legs then really becomes a problem, as well as Parkinsonian disorders. So correcting low iron, so ferritin below 75, is often the easiest thing to do. We sometimes use dopamine agonists, but the thing to remember about restless legs is it suffers from a phenomenon called augmentation. So the more medicines you give and the more you escalate the doses, the worse the restless legs becomes as a response. So that's why we tend to use low doses of medication, and we cycle to different medications, maybe every 2 to 3 months, to stop the body becoming habituated to it. So no habituation, no augmentation. We just keep the body guessing. Change, switch, 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 switch. And that really annoys the GPs because the prescriptions are always changing. But when we see people who've just been escalated on one drug, started on another drug, and they come into clinic and everything's restless and it's just horrible, and you have to wean them off, and so we really don't want to get into that position. So it's one of those disorders where seeing somebody promptly and having a sensible plan is really, really helpful. And then we've got non-REM issues, so non-REM parasomnias. So these occur in deep sleep, not in dream sleep. So it tends to be earlier in the night, as opposed to REM behaviour disorders, which are later in the night or early in the morning. And these are your sleepwalking, your night terrors, confusional arousals where kids scream in the middle of the night, and it's probably nightmares. And it's usually within an hour or two of going to bed. So mum and dad are usually awake, and then they either learn to sort of guide their kid who's having sleepwalking or had nightmares back to sleep. You don't sort of roughly wake them up, you just reassure and guide, and that tends to be the best way of dealing with it. And most kids, it tends to just die down, but a small number of adults will continue with them, and children who are particularly prone to parasomnias, if they get very stressed or if they have lots of anxiety or change in their routine or alcohol, it can re-emerge. Usually we would manage conservatively. Medications aren't usually required. I will say that my friend works in the hotel industry, and most people in the hotel industry are trained to deal with sleepwalkers in their premises. So they would tend to have blankets. They obviously have cameras everywhere. So if somebody walks downstairs in their pajamas, or quite often without any clothes on in the hotel, all the staff are trained just to very gently say, "Oh, hello, Mr. Perkins, how are you? We'll just get this blanket round you and I'm going to take you upstairs to bed." And that almost always is how to manage it. And they will mention to the client in the morning that it's happened, but reassure them that they were fine. So hotels are trained to deal with this. They're probably better at dealing with this than medics are, actually. And then just to touch on other sleep issues, insomnia is very common. We don't tend to see it in neurological practice because, with some very rare exceptions such as frontal brain injuries and things like that, it's to do with sleep hygiene, reducing screen time, improving general health, and sleep training and CBT are generally used for that. We do not live in a good environment to promote good sleep. So blue light from screens, from phones, from TV, that destroys the accumulating melatonin, which tends to build up as the day goes on. So you just blow out all your melatonin, which is supposed to allow a normal sleep to establish, by looking at your phone, and then you lie in bed and you think, why can't I sleep? I'm going to doom scroll. And then this blue light is just destroying your melatonin as soon as you begin accumulating it. So nobody sleeps well and everybody's stressed and everybody's miserable. Me too. But, that sleep hygiene and reducing your screen time, particularly at night, at least an hour before bed, is important. Benign hypnic jerks, these are funny jumps and jerks when you're sleeping, often going from sleep to wake. Some of them can be really scary. There's something called exploding head syndrome, where people just wake up and they're like, ah! And they think their head's just going to blow off. In the majority of people, they might get it once or a few times and it never comes back. But it's well described, but can be terrifying. And I have a colleague who is a neurologist and knows exactly what this is and had it once and said it was absolutely terrifying, even though he knew what it was. And then quite often we're asked to opine on maybe people with learning disabilities or children who have self-soothing strategies. So things like head banging, rocking, going from side to side. This is very, very common in children and often people as they get older, because it just is a way to soothe. And sometimes children can get into these kind of movements and get it in. It becomes a habit after maybe a period of nightmares. And we're often asked, if these are seizures. In the majority of cases, they aren't. Seizures generally in sleep are from the frontal lobe. They're brief, bizarre. There can be other changes such as automatisms or incontinence, which we wouldn't see here. If we aren't sure, what we would do is we would do an overnight EEG looking for seizure activity. So to summarise, lots of problems can cause sleep issues, neurological, general, or just life. Anemia can worsen restless legs. Stress can give you insomnia, but also more serious things like the development of Parkinson's disease can give you restless legs or REM behaviour disorder. History from someone who shares a bed with you or at least is in the house with you can be very, very helpful. What part of the night does it occur in? If it's the first few hours and it's wandering around, it's probably a parasomnia. If it's later in the night and it's clearly dream enactment or someone thinks they're being pursued and they're lashing out, it's a REM behaviour disorder. Recordings from phone cameras, or like nanny cams we call them, they are super helpful. Pet cams as well, where you watch your cat do funny things when you're at work. They are very, very helpful for recording sleep. Knowing what the behaviour is and when it occurs is helpful. If we think it could be seizures, an overnight EEG can be diagnostically very reassuring. The majority can be managed conservatively, but as I said, some may suggest an underlying disorder that needs more investigation. Thank you.